Hey guys, how's it going? My name's Caleb. I'm a medical student on a research year. I take some time on the weekends to interview interesting people that I've met along this journey to help you on your journey. I'm glad that I've had mentors and interesting people to talk to during my time, and so maybe this will help kind of guide you. Today's guest is a pediatrician, Dr. Lori Langdon. She is the chair of pediatrics at our medical school, and she actually wrote a book. Doctors work in air conditioning. It's her life story, and it's quite the interesting tale. She talks about her journey growing up in rural North Carolina, eventually going to Duke University for medical school, and then going on to Virginia for residency, and then going out into practice back here in rural North Carolina. And the timing for this interview couldn't be perfect. We've got a shortage of pediatricians in this country. We've got an administration that seems real keen on attacking the status quo of routine childhood vaccinations. Whatever your political leanings may be, here's an objective look at the direct impact these decisions will have in the future. The stories that she shares are gut-wrenching and emotional and powerful. I think whether you're interested in pursuing a career in pediatrics, whether or not you want to know the pros and the cons, or if you're just somebody that is looking for more information on why we do childhood vaccinations, why this big concern for autism this day and age, Dr. Langdon does such a good job of explaining all of this, and I think I would do it injustice by sitting here and trying to drone on about those things to you. So without further ado, let's get into the video. Dr. Langdon,
Yes,
thank you for joining.
Well,
Thank you for letting me join you on your podcast.
of course. Thank you for coming and interviewing me. I love it.
This is your podcast. We're at your house.
Thank you. That's
It's a
right.
beautiful place. Thanks for having us.
Thank you.
And all our producers,
Right. All good.
Sorry that there's so many people here.
Yes.
Overwhelming.
I love having company. It's fine. Even if it's imaginary.
But Dr. Langdon, thank you so much. For those of you that don't know, Dr. Langdon is a beloved faculty member at Campbell School of Medicine here in North Carolina. And she is a pediatrician. And she is somebody that has really inspired me on my journey into medicine. She's hosted me at this house before, amongst my friends for Thanksgiving, actually. It's about that time, yes.
That's right.
Yeah. We played music. We had,
Makes me so happy that you remember.
yes, it was a lot of fun. And so thank you.
My pleasure, honestly.
And so she also wrote a book, I noticed during our time here in regular school. This is the book, Doctors Work in Air Conditioning. It's going to look at Southern culture, the challenges of rural medicine. So kind of tell me about your origin story. Let's start off with that.
Sure,
Okay.
sure.
Where do you come from?
Sure.
How did you get here? How did you?
Yes, how are we here?
Yeah.
So it is the most ironic thing, I think, that Campbell University decided to build a medical school here in Harnett County. Harnett County is sort of halfway between Raleigh and Fayetteville and has always been extremely rural. I grew up here in this very county. I was born at Betsy Johnson Hospital in Dunn, the very building that it's still in right now, one of the first deliveries there. And I grew up on a hog and tobacco farm. And in this area, in that time, the people who did the work were just the local teenage boys and the children of the farmer. And so I grew up driving a tractor by the time I was 7 years old. Funny story, I was too short to reach the pedals because I'm 4'10" now, but when I was a child, I was very short for my age. And so I would have to climb down from the seat and stand on the pedal and push on the steering wheel to get the pedal. Well, one day when I was 5 years old, we were in a tobacco field in July. It's 100 degrees in the tobacco fields in July here in Harnett County. And I asked my parents if girls could be doctors. And they said yes, which is surprising because my dad wasn't exactly a feminist, but he had gone to high school with someone who grew up and became a family medicine doctor, Dr. Linda Robinson, who came back and practiced in this area. And she's retired now. And my next question for them was, do doctors always get to work in air conditioning? And they said, yes. And I said, sign me up. And so my goal at 5 years old was to be a physician. because I wanted a guaranteed job in air conditioning. That is a real and very true story. And fortunately, it went on that I love people and I love children and I love science and I did well in school and all that. But that was the beginning.
Well, that sounds like that's always been you. You've never changed. We were talking a few minutes ago about a local representative
Yeah.
was promoting you openly to
Very
other people
sweet,
about being very nice and saying how amazing you are, proclaiming your greatness to everybody else. And I go, well, have you thought about doing anything with that? And she says, oh, you said, yeah, I'd like to get more money for our health center here at the university.
Yes, yes.
I'm sitting there thinking about like policy and all this stuff. She's like, I'm just worried about the people that I'm taking care of
Right.
here, local, at home.
Right.
And so that seems to be your passion. And that's why I've enjoyed getting to speak with you and getting to learn from you during my time here at the medical school. So the spoiler, I go to Campbell. Haven't told anybody. I try to like
Surprise.
protect, but I
Right.
guess, are we promoting the school? It's a great,
I mean, it doesn't
great
matter.
program.
It's a great program.
program.
Absolutely. It's the only DO school in North Carolina. And I think that the North Carolina Pediatric Society, shout out to them, has been very instrumental in including me so that I've gotten a better relationship with the other chairs of the other medical schools. And that in turn helps all of us because we have a pediatrician shortage. And so by my knowing the other programs and they're respecting us and our grads who are going into pediatric residencies, it's just a beautiful thing to know. There, 4 other medical schools, now 5, 'cause there's a new one in Charlotte out of Wake Forest University, but they're all allopathic. And then there's going to be another new one in Fayetteville soon that's also allopathic. So we'll still be the only DO school in North Carolina. So we're unique, I think, and special with our emphasis on primary care and specifically rural, underserved primary care.
Yeah, okay. I mean, we're gonna hop around a little bit here if you're okay with that, but
How I live.
that's how my brain works.
Yes.
Our conversations are very all over the place,
Absolutely.
but productive.
Absolutely. I hope.
So how do you end up, for everybody that doesn't know, you went to Duke for medical school, right?
Which is not really consistent with my story of poor and rural, is it?
No.
Okay, so here's where the trajectory changed. My life story is not since the book. So I was in a cult as a child. Okay.
Sorry to laugh.
Yes, it's okay. And so I was taught that girls could only grow up for 2 career options.
Mhm.
They could marry a pastor, or they could play the piano. Or the very few golden children could perhaps become a piano player who married a pastor. Gasp. And I was never really good at my piano lessons and did not fall in love with a pastor.
Yeah.
And so that was not working out well. And thankfully, my mom saw through the cult in just the nick of time because they have their own associated academy. So I was in the academy there up through 9th grade. Well, it turns out we didn't learn any math or science. We only prayed about God using math in our lives, which is important, but also the learning of the math is important.
Yes.
So
I apply it.
yes. So that was 9th grade. I got, so we figured it out. Thank the good Lord, got out with much shame and much guilt. I would get in trouble there because, I've got a bubbly personality. I've confessed that before. And I would smile or laugh. And there, that was wrong. And it was also really, really uncool to be a girl who was smart, except when I quoted scripture at length on stage. But anyway, and so,
Forcibly.
yes, under duress. Well, I would get in trouble for smiling or laughing because that meant that I was not aware, I'm not making this up, of the gravity of my depravity. I was told that by all the adults. Quit smiling. You're giving it away that you're not aware of the gravity of your depravity. Get preached at from the pulpit. Lori Moore, she's not aware of the gravity of her depravity. Come repent with tears, because you got in trouble if you repented without tears. Not kidding. And that was the whole no jewelry, no makeup, obviously no tattoos, no pants. Women couldn't wear pants and all that. Well, anyway, so we made it out just in the nick of time. So I went to public school in the 10th grade at what was then a K through 12 school in Coates. And I was convinced when I got there that the hallways would be filled with sex, drugs, and rock and roll. And it turned out most of the teachers were believers and went to the Vocal Baptist Church. Anyway, it wasn't at all what I had expected based on my brainwashing while in school. Right, yeah. And I even met my husband there. And on our very first date, I did tell him it was going straight to hell because he was listening to rock and roll music. And that has a syncopated beat, which is from the depths of the satanic influences in Africa. I had been taught. Fortunately, finally got around that, even though I did wear skirts that whole year, 10th grade. Well, in 10th grade is the year you have to be nominated to go to this amazing place called the North Carolina School of Science and Math. And my biology teacher, which I had to take as a sophomore, very embarrassing because you're supposed to be a freshman class for biology, but I hadn't had biology at the cult, of course. So I took it, loved biology. So all of a sudden I was like, oh, wait, that whole 5-year-old dream in the tobacco field is back in play, baby. Yeah. And so that biology teacher nominated me for NCSSN. My guidance counselor there at Coates K through 12 was nice enough to tell me that I could not go because no one from Coates had ever gotten in. Thanks, guidance counselor, who's supposed to be on your side trying to get you to overcome suffering. So in these tiny little schools, in these tiny little counties, we didn't have AP courses. We didn't have AP bio. We didn't have physics as a class at all. None of the stuff I needed. And I did get into science and math, which is probably where my whole life story changed and the trajectory changed dramatically. So from science and math, I thought, well, I'll go there and then it'll be easier to get, scholarships for college and things. It turned out it would have been easier to get those from Harnett County because then I was competing against, 200 other kids that were super bright from around the state. But I did. God provided. I got a full scholarship to NC State. It's called the Park now, but at the time it was the Caldwell. Anyway, full scholarship, fabulous, because we were poor as dirt. We lost the farm that I grew up on to bankruptcy in the 80s, as did a lot of farmers. And so we had looked into my going to Wake Tech, but we couldn't afford it. So we couldn't afford a technical school, but then I got a full scholarship at college.
Wow.
Crazy.
Yeah.
Well, then I got married when I was 19. That same guy had told he was going to hell. And and he was a farmer. He went to NC State for agricultural training. And I had sworn as a child on those sweaty days in that stupid tobacco field that I hated that I would never marry a farmer. I swore before God and everybody. But of course I did. Best decision I ever made. And so we got married. That's exactly right. So he had the wherewithal to be able to be a stay-at-home dad years down the road, which a lot of men wouldn't because they associate their own personal identity in their career, and he was willing to stay at home with kids. Huge, highly recommend for all physicians who plan to have a lot of children. Oh, that's exactly right. He had plenty of work to do. Yes. At one point, he homeschooled 7 children because we got an additional foster kid. Anyway, he's amazing. Well, so we got married when I was 19 at NC State. And so he was working at, he did official varieties testing with the crop science department at NC State after he graduated and was working on his master's. But anyway, obviously I couldn't afford medical school. And I only applied to UNC and Duke because he needed to keep working in Raleigh.
Oh, wow.
Well, I got into UNC and Duke because I had a perfect GPA. But anyway, it's fine. And a good interview, and they were really proud of me. This is how I roll. And so I did get into Duke and UNC, and North Carolina has a program. The Board of Governors has a scholarship for smart poor kids. It was great. So the Board of Governors.
What's it called?
The Board of Governors scholarship.
Oh, okay. It's called the Smart Wicked.
No. And so I did get that, but I also got, there's this, at the time there was something called the Fullerton Foundation out of Charlotte, and they wanted to give scholarships for medical school to students from North or South Carolina who plan to do primary care. And I didn't know yet exactly what I wanted to do when I entered medical school, but I knew I wanted to do primary care probably in a rural area. And so I did get that Fullerton Foundation scholarship, and then Duke, being very kind and with generous endowments, said, hey, we'll match the full ride of the Board of Governors. Take what Fullerton gives you and we'll make up the difference. And so they did. So I was very blessed to have a full scholarship to go to medical school at Duke. And that's how we're here.
Wow. Okay. So you're at one of the now best regarded medical school in the nation.
Of course.
And we talked about this a little bit earlier, but you're in this great place to succeed. So the way that Duke works, if people don't know, I'm going to give a little bit of a shout out to Duke, I guess. Why not?
Sure. They were generous to me.
They did well with you, right?
Rough, not a collaborative learning environment. Very rough hierarchy of attendings to residents to med students. But other than that as well, great academic place.
Very much academic rigor.
Yes.
Focus. Yes. So you do all your pre-clinical years in 1 year.
Correct.
You do your rotations your second year.
Right. And second and fourth.
And your third year.
Research. Yes.
Research. So you are set up for success.
Yes.
To do something more lucrative.
Yes.
If you had wanted to.
Yes.
You always had the grades and the drive and the motivation to do all these things. So why pediatrics?
That's a great question.
Yeah, I say that. I mean, I'm not, you understand, I'm not downplaying pediatrics. I
know. You value it. Absolutely. Yes. All respect for peds.
For everybody else, how does that decision?
So many things went into it. Originally, I was thinking maybe OB-GYN, but realized even on my OB-GYN rotation, my heart was with that baby. I wanted to go with the resuscitation of the baby. I wanted to go to the neonatal intensive care unit and see what happened to the sick babies. It was all about that baby. And then as I did more and more rotations, Funny story. Let me give you a little insight to my medical school years.
Yeah.
Duke University School of Medicine is just across the street, Irwin Street, from the Durham VA. And so many of my rotations were at the VA.
Yeah.
Not peds. So I do joke that I chose peds because it was one of the few things I didn't have to do at the Durham VA, which at the time was in quite a state of disrepair. I will share a funny story about that. It's a rumor, but it's true, that if there is a juicy procedure that we Gunner Duke med students want to do at the VA, but they don't have the fancy new modern equipment to do it as easily. If you, the medical student, with your also short white coat, can acquire it from the main hospital and walk it across the street clinging under your white coat, you get the procedure. So I did a thoracentesis as a second-year medical student because I acquired the material from the main hospital. Please don't put me in jail or anything. Everybody did it. It's a thing. It helped our veterans. God bless America.
You were supporting our veterans.
Yes. And so if you got the equipment, you got to do the thing. And I got to do the thing. That was pretty cool. And I got the fluid out and he felt much better. His stats improved. His shortness of breath got better. His dyspnea resolved. His dyspnea resolved. It was great.
But you got to do thoracentesis?
Yeah. Because I stole the equipment, man. You know, that's great.
Jeez.
Anyway, so between all of that and lots of rotations in the emergency department dealing with stinky old adults, I very quickly learned, but wait, I love the children, but wait, they deserve everything I can give them. But wait, and you know, let me preface this. We teach all of our medical students, you know this, do not judge the patients. There's no room for shame. There's no room for judgment in medicine. We love you. We want to take care of you. We want to give you the very best care possible.
But you had a predilection for
the children. Yeah.
Children.
And that being said, no judgment. There were so many frequent flyers in the adult emergency department that did have alcohol use disorder, and that could be demanding and that could be difficult. I remember thinking to myself, every now and then I have like a very clear, crystal clear memory of something. I remember thinking, you know what? I think I'm going to get burned out and lose my motivation to do my very best for these patients every single day. If they're just cussing me out and screaming at me and they're just here because they won't quit drinking, you know? And I remember thinking, nothing a child is here for could be their own fault. They deserve my 100% best, my keeping up with guidelines, my keeping up with my CME.
Not that anybody else
single
does
day.
it.
I know, but I'm just not going to lose my drive on them. And the intervention I could make when you think about the life years, the trajectory in their life that's still left to live, you can't beat that. And then there's the adult sputum problem. I can't do it. I can't handle it. Nope, not going to do it. So I never have to do adult body fluids anymore. Praise the Lord. Like anything that comes out of a baby, I can handle. I don't care if a newborn pees on me, spits on me, poops on me. I got it. That's no problem. But an adult, heck no.
Well, we talked about earlier too about the surgery lifestyle and how hard it can be on people.
Right.
But it sounds like from your journey that you kind of lived a pseudo
equally challenging, yes,
surgeon's lifestyle, even in pediatrics.
Right. So some of this was my own fault.
Okay.
Let me take you back in the day. So I did residency from 95 to 98 at the University of Virginia in Charlottesville. Beautiful place. And it wasn't UVA's fault. It was just how things were back then. There were fewer advanced practice providers. These days, in the NICU, in the PICU, you're going to have a ton of APPs, PAs, and nurse practitioners doing, honestly, the bulk of a lot of the work. The note writing, the order writing, the lab checking, the rounding, so much of the work, right? Back in my day, house staff covered the ICUs. So there wasn't a month when I didn't have overnight call ever. Even if we did an outpatient rotation, we took ER call. I'm not kidding. It was brutal. Mark, my husband, would time my hours at hospital. It was 100 every week. No joke. So we'll talk about in a minute. I had a big.
Now, was that like
PICU, NICU, inpatient? Oh, yeah.
Or was this just your own drive to?
No, that was the rule. It was just how it was. It was how it was. I fell asleep so many times on the way home, and I'd been in the hospital for 40 hours in a row with no sleep. And I would be driving and just, every time there was a red light, I would have to wake up to the cars behind me honking so I wasn't moving. Wake up and drive. It was horrible.
Wow.
It was based on this. It just started in the 1800s by people who were literally using cocaine at Johns Hopkins. You've heard this story. Yeah, the whole mindset. And the mindset was that we physicians are so superhuman that we don't need sleep. We can make smart decisions when we've been awake for 24 hours. That's not even logical, but I promise you that's how it was. So I would get there, let's say Tuesday morning, for example, and pre-round and then round with my attending. So, like get to the hospital, my baby 5:30 or 6. And then I would work all day, work all evening, work all night, pre-round again, round again, work all day, go home and give sign out to whoever's on call for Wednesday night.
How many days a week?
So every third night call usually, or fourth, depending on the rotation, usually third. Right? It's brutal. Brutal. It's ridiculous. We wouldn't do that now. We can't do that now. So we have more help, and the hospital systems aren't putting all the weight on the shoulders of the house staff. But we did then. Okay, so that leads to
Okay.
I got so good at that stuff, man.
Yeah.
We had to do, so for preemie babies who are critically ill, a lot of times they need an umbilical arterial line or umbilical venous catheter. So UAC, UVC. I could do an art line on a 2-pound baby in seconds. I mean, it's all I did. I could intubate 24 weekers, 2.5 ET2 tubes. When I see like in SimLab, when I see those ginormous, vulgar, horrible looking ET tubes, like the ET tubes we live with, they're just so tiny. Anyway, that's all I did. I was good at it, right? I mean, I could do the things. So I remember when I was looking at coming back to a rural area, I looked around in North Carolina and realized there had never been pediatricians here when I was a kid. There was a pediatric practice in my home county. And I thought, what good fortune. Idiot. What good fortune that there's a pediatric practice in my home county. And the kids, because I had another baby at the end of residency. So first baby, 4th year of medical school, second baby in 3rd year of residency.
Yeah. How big is your family, by the way?
So we have 6 children.
Okay.
Yeah. Because I love children. I love children so much. So we went on the funnest field trips and we have a 15-passenger van so we could accommodate all the friends of the children, so we could take all the kids to Carowinds and whatever. It was great. So when I looked around and found this small practice, they had hospital privileges. And so I knew, I went into this knowing what could happen, but not really knowing or understanding the consequences of full hospital call in a rural area. Yeah. And so when I signed on for this, at a very small salary, by the way, we're just going to be candid here, right?
Sure.
$95,000, Duke Med grad, UVA Peds residency, full call in the hospital, worked all the weekends, 40 patients a day in the clinic, every Q3, and $95,000. There were RNs in the hospital that made more than I did. It was insane. And I had at the time, so a 3-year-old and a newborn, trying to nurse her. First day I worked, I never got to pump once. I was about to explode. It's a miracle I didn't get mastitis and that I was able to keep up my supply. Insane. Well, anyway, so let's say you're on call during the day. You get a stat C-section over at the hospital. You run across the lawn to the hospital to resuscitate, not to do the section, but to resuscitate the baby. The OBs at that time had the highest C-section rate in North Carolina. They got investigated by Medicaid many times. And so peds had to attend every single section, not just the stat, not just the fetal indications, not just the we lost the fetal heart tones, every single one, scheduled, all of it. And then often do what was going to be a scheduled section, but they came in labor at night, they'd do them overnight. So I was all the time going to the hospital overnight. It was torture. But if it was during the day, you ran over there, you came back to the office, and all the patients that had been scheduled for you were still there waiting to be seen. So you were just praying that it was a healthy baby and you could come back quickly and write your orders and everything. What if it was a sick baby? Okay, so the worst things that happened to me were, and when they recruit you to these places, they say, don't worry, if you get a critically ill neonate and we have Jacks go out to resuscitate him out here, no help, just call a helicopter. And one of the life flights from UNC or Duke will come get him, right? No big deal. Cool. Guess what? They didn't fly in thunderstorms. Guess when they told me that? When I just delivered a critically ill neonate in a thunderstorm. And you're so suddenly it hits you because you come from residency training when you're surrounded by all the attendings.
And all the help that
yes, you have a pulmonologist. You have the neonatologist at your backup. You have the critical care person that pick you. You have everything you need. When you hear a weird murmur, you just get cards consult. No big deal, right? Until you're out here in the middle of nowhere, you're everything. Does this kid look syndromic? Maybe. Was that a murmur I heard? Maybe. I need to call a friend. You don't have any friends. You're by yourself. And it was one of those C-sections when it was just crap hit the fan. Baby was doing terribly. Nobody helped me. One time so I did have a baby that was born with an Apgar score of 0. That means, for non-medical folks watching, Nothing. There was no heart rate. There was no pulse. There was no respiratory effort. Nothing. Baby's blue, limp, non-responsive, nothing. There is nothing happening here. And so I realized then that nobody else in the hospital is trained in our neonatal resuscitation protocol. So not only can I get a consult from a specialist, I don't even have a nurse. And when you're bagging a baby, it's better if somebody else is doing the chest compressions, right? What the heck, man? It was terrifying. That was horrible. So I did that level of full call for 10 years. And it is not sustainable.
How'd you...
My husband's a saint.
Yeah, how would you...
That's the only way the children survived. I was burned to a crisp. At one of those locations, and I swirl chronology in here. I don't want to get sued by anybody. I don't want to breach HIPAA. So in the book, you can't really tell which hospital system I'm at the time, so I don't offend anybody. But honest to goodness, it's just sort of a generic representation of how it could be anywhere in a very rural area.
Okay.
So one of the situations I accidentally got myself into is I got recruited to a rural hospital and told, we'll recruit 3 other pediatricians. And I had been in a decent situation with 4 pediatricians. You could each take call Monday or Tuesday or Wednesday or Thursday, just 1 weekday and 1 weekend per month, Friday, Saturday, Sunday. That's hard work, but it's doable. It's sustainable. I got to this situation and they didn't recruit those other 3 pediatricians. They recruited locums, and the locums couldn't intubate. The locums couldn't do umbilical lines. The locums couldn't do anything. And so I would get, this is what happened more than once. 4 a.m., my beeper goes off, my pager. We used to have pagers because I'm old, right? It would go off. I'll call back and they would say, hey, we know you're not on call, but we've got a 2-month-old in the ED who's seizing and anesthesia can't get him intubated. If you don't come in, they'll die. But you don't have to come in. I went in. What do you think I did? Of course,
Yeah.
but you can't live life like that. And so it was at that point, I didn't sell out. I was still practicing in a rural office, but it was part of a much larger modern group, biggest pediatric practice in the Raleigh, in the Triangle area. And we would take, like I would still have office hours in Raleigh on Saturday and Sunday, but I was seeing patients in Johnston County, which is a rural county near here. And in some ways I felt guilty. I literally had a patient that was born after I left a small rural place and she didn't get adequately resuscitated. And she had hypoxic ischemic encephalopathy, the whole thing, the trait, the G-tube, blind, deaf, seizure disorder, nonverbal, in a wheelchair. Horrible, 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 sad story. And I felt so much guilt because if I'd been there, she would have been a normal kid. She just wasn't resuscitated when she was first born because there was nobody there to do it. And so there's a lot of heaviness to this. Peds is happy. Peds is fun in the outpatient but resuscitations, ICU stuff, it's heavy. And that's part of why I could never have gone into ICU care. I'm just too mushy heart. I can't take it. But I was pretty good at those resuscitations. With zero respect, when I started at that little hospital in 1998, I can't make this stuff up. The doctor's lounge was only for boys. For real. And so I would get to those stat C-sections that those OBs called all the time in the middle of the night. And I'm jumping in my bunny suit and get my, footies on and my hat and all the things and running in there because they had said we lost fetal heart tones. And I'm like, oh, I know I'm going to die early from the amount of adrenaline surges I had during those stupid things. As I'm running in there and the OB guy says, is that girl here yet? What, that girl is going to improve your outcomes and save your butt on your liability? Are you kidding me? That resuscitates these dead babies you keep pulling out? Yeah, that girl's here. Except I didn't say that because I'm nice and I was raised in the South and I'm passive aggressive. But I said, yes, sir.
Bless your heart.
Yes. Bless your heart. I'm here.
Yeah.
Oh, yeah, it was a time. It was a time.
It sounds like it. So, I mean, now I'm starting to see why maybe you chose with your pedigree and whatnot. Maybe I should go encourage some more people to work in rural primary care areas because
we need it.
we desperately need.
Yes, we need
Because you're still out here. You're still out here. Yeah.
We need colleagues who follow guidelines. We need colleagues who don't end up in rural areas just because they couldn't get anywhere better, right? And that's what happens. And so the quality goes down. And so then the patients don't trust the local physicians. And then the patients with insurance and money and resources and access to transportation go out of county for higher quality care. So standard of care, a lot of young people don't know this. I didn't used to know this. Standard of care, even in liability situations and malpractice lawsuits, depend on the county you're in because the standards vary by county. Isn't that nuts?
The standard of care?
Yes. If you get a lawsuit and say you weren't following standard of care varies by county. Well, in this county, yeah. Oh, there are counties around here who have family medicine and newborn nursery. And there are counties around here, not that far, because we have a wide variety around here, who you would only have, like, if something happened, you'd have a neonatologist responding to any
So
situation
they kind of have to make the standard of care be what is
based on
what
what's
we
available.
have. Yeah,
That's
what we
exactly right.
have.
So
So it's not like it's
right.
evil.
No, it's
Fine.
literally
It's just-
different. It's
yeah.
dramatically
It's just
different.
different.
So if you go from Harnett County, well, now we don't even we're a maternal health care desert. There's not even deliveries here now. They closed the OB at the local hospital. There are no deliveries in this county. Yeah. And, but
Where do they go?
usually Wake County. So in Wake County, the closest to here is UNC Rex Holly Springs.
They don't do
Deliveries.
They don't.
Nope, no deliveries now. There were a lot of bad. It is better. It's very sad to have a loss, but outcomes were poor. I'll say that.
Okay.
So,
Yeah.
from my inside knowledge, it was all for the best. All for the best. Well, for the main thing is, we couldn't even recruit anybody. We couldn't recruit peds. We couldn't recruit OB. So, a huge part of the problem of rural medicine is we can't get anybody who wants to live here. For decent reasons. Maybe their spouse can't find a job here. Maybe they're not happy with the quality of the public education here. Fair points, right? And then there's the whole issue, too. This is kind of humorous, but it's true. Do you want to practice medicine in the same community where you go to that Walmart and you'll see all your patients, the Walmart rule? Or do you want to live 30 minutes out of town and you drive in to do your care and you drive home and you go to a different church, Walmart, all the things, right? And I'm all in. That's just who I am as a human. So, I go to church with my patients. I see my patients at Walmart, but I can't go to Walmart. My kids hate it without a sighting, Oh, Dr. Langdon, I've got this rash. Hey, I'm not kidding. I've seen post-op wounds that were like 24 hours old. Hey, do you think this is healing well? And they just pick the kid's shirt up. The kid's not loving it either. I'm like, oh dear, well, you just follow up with your surgeon. Yeah, that's great. Do it. I'm not kidding. The number of times I have had kids with huge head lacerations when I was at choir practice come in, walking down the aisle to come get. I've had kids vomiting in my bushes on my front yard. Parents brought them here to my house. Oh yeah, I have been to visit a rectal prolapse at their house. I can't tell you. I've done glue on headlocks on my kitchen at her.
I don't want anybody to get
my
the
island.
idea.
Don't do that. We don't love it.
Don't do that.
Don't do that, please. I'm sure it was horrible. Don't tell my liability holders that years ago. Haven't done any stitches in my house lately.
Yeah.
Hope not to. But yeah, it's very hard to maintain the boundaries of professionality. And it's very easy in a rural situation for people not to realize you're a human being, right? And so, for example, at a practice which quit paying for overnight nurse triage, even though it's standard of care in pediatrics, they just all call me personally. She has passed away, but years ago, my husband's grandmother, she was well over 90, little old lady with light curly hair. My children's great grandma, people would call her home phone to get our phone number. Isn't that precious? And I wasn't on call. Like, I took full call. Like, there were certain nights you were supposed to not be on call. There was never a night I wasn't on call. Because my name was in the church phone, church directory.
Oh, boy.
It was a large church.
Now, is that... How much of that do you see as a blessing versus
That's a great question.
a curse? What's the blend for you there?
The bless is people love me, but then you wonder if they only love me because I can help them. They don't call me to say happy birthday or I hope you're doing okay since your dad passed away or your stepdad passed away. They only call me to see if I can call something in. That sounded bitter. I'm sorry. That was honest. It's true. It's true. And I'm realizing it more as I get older because now that I'm not in a normal peds practice, I'm in a health center scenario, I can't do the favors for them. So they don't call as much unless they just want straight up advice. Which is also a liability to me because technically, and I try to say this is generic advice. If I don't have a patient-physician relationship with you actively now, if you are not a patient in my clinic, I can't give you individual advice. I can say, in general, a 3-week-old baby with persistent severe vomiting and decreased urine output needs to be seen. Because it could be pyloric stenosis, but I can't tell you your baby needs to be seen today for persistent severe vomiting and decreased urine output.
Okay, so you've already kind of introduced the topic.
Sorry, I'm all over the place.
No, it's okay. It's how I roll.
Good,
So
good,
I'm happy we're on the same
good,
wavelength
good,
because it just works.
good.
Um, let's go positive just for a second
Yes.
because
Oh my goodness, so much.
you've passionately shared your experience and what you've learned. And that's what I want everybody to see is this is all stuff that you're just picking up as you're going. You didn't know what you were asking for exactly when
Right.
you got into the situation to begin with.
Yes.
And so if you were to, and that's why I kind of informed what I assume your journey into academics, right? To encourage the next generation.
Right. Absolutely.
So how do we encourage the next generation of students to take on the challenge of being in rural medicine if they may not have help? How do we even
So I think one thing that
to
helps
do
is
that?
maintaining their own mental health and having a good spouse.
Mhm.
That's huge. We were near family to help us when the children were younger, so we could get a tiny break. I think that most of the young people now, they've been warned and they know that you've got to set boundaries. I didn't feel that I had the ability to do that. They wouldn't have hired me for the job I did if I said, I can only work 2 or 3 days a week. That wasn't an option back then. There were no shared jobs. There were no call-free positions. There was no such thing. There are now. There are better opportunities now. Again, they're usually in larger places now. That's the tricky part. There are situations in which people could be owned by a hospital, maybe hospital system. Pros and cons for that, for sure. I've worked in every kind of. I've been in small privately owned. I've been a partner in a small privately owned. I've been an employee in a large privately owned. I've been hospital owned. I've done all the things.
What's been your favorite? I mean, as far as your personal preference,
Partner.
you can partner,
Yeah.
having that ownership.
Right. You get to make the decisions. You get to do what you believe is the best thing for those patients and for yourself, even when it's hard. When the hospital comes in, they get to say, you can't have a CBC machine. And then you have to say, I've never practiced medicine without a CBC machine.
I can't even.
I'm on the board of the hospital. I'll go before the charitable foundation and request a CBC machine. Oh, don't make a fuss. Fine, we'll get you a CBC machine. But we won't get you a CBC machine unless you're the lab director. But I'm not a pathologist. Oh, but you can just do 50 hours of CME and then you can be the lab director. Okay, I'll do it. I did it. I got a CBC machine. You see what I'm saying? It's a lot of work.
How do we fix this?
Yeah, I don't know. That's a bigger discussion. There are solutions. I think we've got a lot of maternal health care deserts. We need to recruit high quality OBs to those areas to do OB and GYN work.
Mm.
Even within OBs, part of the issue in peds, let me go back, is
Sure.
adults figured out a long time ago how to divorce inpatient and outpatient duties. We in rural areas haven't figured that out. In larger urban areas, we have. So in the Triangle area, plenty of practices you could do outpatient only. And you send your admissions to Wake Med and they have hospitalists. And the neonatologists cover sick deliveries. And you could or could not round on newborns and still maintain a perfectly huge and healthy and thriving outpatient only practice. You would take night at call just for a phone call, right? And if you had nurse triage, even that wouldn't be too painful. That's doable. Then you get a little bit out further into the rural areas, and it varies. If you were in a system that you could still refer all your kids back to that larger university or big system like Wake or whoever, whichever county you're in, then you could still have a decent life. If you're responding to stat deliveries, you're going to need a very large practice to have a decent life. Other options are you could recruit groups of neonatal nurse practitioners, contract them out. They could be remotely supervised by neonatologists at bigger groups in other counties and provide extraordinarily high quality care. And you wouldn't be tied to going into every single delivery.
So,
Huge.
Paul, and pause you for a second.
Yeah.
We talked. There's a lot of talk right now about mid-level encroachment and stuff like that. It sounds like in the neonatal world, in pediatrics world,
We need them.
we need them
Yeah.
desperately.
Yeah. And a lot of APPs aren't choosing pediatrics. It's part of the pediatrician shortage. Medical students aren't choosing pediatrics. They've heard the horror stories. They know the challenges of rural health care. They know it's hard to deal with those situations of child abuse. They know the bad side, but maybe they don't know the joyful side. Or maybe they've heard in rural you're worked to death if you have to respond to every single neonatal resuscitation situation. I had one time on a Sunday, I was rounding at the hospital. I had 18 newborns to round on, so I didn't make it to church that day. 18. It's too much. If I had a PA to help me, if I had a nurse practitioner to help me, even one who could just help with call, if there was a neonatal nurse practitioner group and they rounded on all the newborns and attended, high risk deliveries, huge, huge.
So in your estimation, do you feel like it's a systemic lack of support for the practice of pediatric medicine, or do you feel like it's just the nature of the beast of pediatric medicine? Do you understand what I'm saying?
Yes, there is a lack of support. It is a unique situation, pizzas, between covering deliveries, being available for same-day visits. I don't know if you've seen an internal medicine doctor's schedule. You could look at the schedule a week ago. It'll be the same schedule today, right? If a 75-year-old has a sniffle, occasionally you may be able to be worked them in, but most of the time they're going to have to go to urgent care or something like that, right? Because you've got your hour-long, unbelievably complex, 25 prior high-level diagnoses, right? Whereas in peds, we schedule intentionally so many well visits a day, but we have to leave some openings. We got a newborn that just got discharged from the hospital yesterday with excessive weight loss. They got to be seen today. We got to recheck their bilirubin. There's not an option to put them off to next week or to send them to urgent care. We have to see them. Or a kid's got a high fever and the parent's nervous. Understandably, we have to see them. And so it's just everything's different about peds. How we schedule, how we get reimbursed, unfortunately, also unfair as far as systemic support. How somebody has to be available in the practice to respond to admitted patients, to round on them, to write their orders, to check on them, to take calls from the nurses about them, and to respond to newborns and to round on them. So it's just different. And there can be a split of inpatient and outpatient duties. That's just much trickier with a lack of pediatricians and support staff in rural areas.
What if there was a specialty for purely inpatient?
So a lot of IMPs
Yeah.
are choosing to be rural hospitalists, and that's huge. It's good part of the solution for sure. So, IMPs is 4 years. Instead of FM is 3, and they do not get the IREs on the trail.
I'm
Right.
beefy, sorry.
Yeah, there's an IMPs that's 4 years of residency, and then you're board eligible to take PEDS boards and internal medicine boards. And we have every year from QSOM, at least, we have 1 to 2 students because both I and the chair of internal medicine provide their letters of recommendation and their counseling and advice for, residency match. There are fewer residency programs for that in North Carolina than there are for IM or for PEDS. So it's slightly more competitive than straight either one.
Okay.
But what beautiful, and I try to tell them this, doesn't mean they'll choose to do it, but what beautiful hospitalists they could be. Wouldn't that be amazing? And there's something lifestyle preserving about doing shift work, right?
Yeah.
There really is. And so I felt like when I was the only peds on the whole hospital staff and got called even when I wasn't on call, I honestly felt the burden on my shoulders of anything that goes down bad right now in this county for this hospital. It's me. And it was, because there was once a really sad story I'll share with you. A 10-year-old child came in. This is years ago. It's a horrible year. Came in through the emergency department. I'll mention this here too. Do you remember there was a study in October of 24 out of Stanford that 80% of U.S. emergency departments aren't equipped to handle pediatric emergencies?
Yeah.
So one of my Langdon laws is a genuine pediatric emergency deserves a genuine pediatric emergency department. And some of them, we discussed, even say they're pediatric emergency departments, and they are in fact not.
So for everybody
Pediatric.
listening, what are those pediatric emergencies?
So a genuine pediatric
Yeah.
emergency department should be staffed by people who have been trained in pediatric emergency care. And that's a whole thing. It's not just somebody who feels like working in an emergency department.
No.
Or an adult emergency medicine person. Those emergency departments should have PICU backup, pediatric intensive care unit backup. Those emergency departments should have ped surgery on call. They should have subspecialists on call to respond to those genuine pediatric emergencies, right? So for some of these tiny little hospitals pretending like they've got a pediatric emergency department, it's a lie. It's a problem. It's fake. Fake news. Dangerous. And then I've seen some of those kids in follow-up, and they didn't even follow guidelines from the American Academy of Pediatrics.
I know an ER.
Which is a dead giveaway, right? That, hello, you didn't even do what you're supposed to be doing if you were even just a general pediatrician and you're claiming to be a pediatric emergency department physician. You are not. And preferably, they also have conscious station rooms. They also have child life to help kids with stressful situations and all that. Anyway, this kid comes in, small local hospital, no adequate training. ER physician attending sends the child to the peds floor that doesn't have anybody They scramble up a nurse to cover, but there's no in-house peds.
Mm-hmm.
The locums doctor was on call, didn't come in. Kid was unstable with documented unstable vital signs in the ER, sent by transport. Transport people in the hospital, I appreciate them so much, but at least at this time, many years ago, those are high school grads. They're not medically trained people. They're people who grab the bags and are nice enough, and we appreciate them, and they push the kid in the wheelchair into the elevator. Child codes in the elevator, covered in a particular rash and stable vital signs. Did I mention that? ER physician was poorly decision making that night. Child was not stable. Should have been airlifted out.
Yeah.
Sit instead, just be in house with nobody to watch them or evaluate them. Locums physician got called to the code, didn't get there in time. ER physician ran to run the code, as they daggum should have, because they're the reason the unstable kid got was. Anyway, child passed away. And that time I didn't get called. This was not my patient in real life in clinic. I had never met them their entire lives. I was not on call. I did not get called, okay? And they had printed out the whole case on paper. And for the most part, we were still on paper at that point anyway. And it was like this thick, just from that one encounter. Because by the time you document the code and the initial visit, it was huge on paper. And as each piece of paper was printed out, guess whose name was on every single freaking piece of paper? My name's. I flipped the slap out and got out of Dodge. That's when I bet that was the end of my 10 years of full call. That's what did it.
Oh, yeah, that'll do it.
Scared me to death. And I'm personally, I'm a careful person. I'm not a big risk taker. I'm liability averse. And most peds are extremely compulsive. We know how to do the math for milligrams per kilogram. We're not just sloppy people. We're very, and so something like that, it just blew my whole mind. I couldn't tolerate that or take that, mostly because the child was dead, and I didn't know about why didn't they call me that one time. And I can't walk around for my whole life worried about every single child in the whole county. I can't. I've got 6 of my own children. I can't. Everybody needs the chance to be off call. Everybody. It's mentally, it'll ruin you. So that's when I went to the larger practice, when I just rounded on normal newborns at large hospitals.
So is any of this still going on today? Have you heard any stories from
So part of why we don't have delivery in this county now. Yeah. Yepers. And it's sad. And we need to fix it. And
it's man, the more that we talk about it, it doesn't sound like it's really on everybody's radar as far as healthcare concerns.
That's why I wrote the book. I wrote the book for a lot of reasons.
Yeah.
To point out healthcare disparities for children, specifically in rural areas. There are healthcare disparities for everybody in rural areas. All of the chronic causes of death in adults are higher percentage-wise in rural areas for many reasons. Socioeconomic status, lack of access to transportation, many, poverty, mostly, lots of reasons. Maybe difficulty attracting high-quality physicians to rural areas, which is part of what... If I am bitter or kind of pissed off at this point, now that I'm old, there are a lot of parts to that. I get frustrated that people assume if you're practicing a small pediatric practice in a rural area that you're stupid. Because if you were smarter, you'd be practicing in the Triangle with higher quality practices. And maybe you would be. I mean, at this point, I'm just getting burned out over. It is hard to recruit smart people to small places. It's hard. They need their spouse to get a high-paying job. I didn't. My husband stayed home full-time. I knew these people. These are my family. Heck, in this county, you're related. I'm probably related to half the people in the county, somewhere or other. We all are. We're all interrelated. Hopefully not intermarried, but it's always possible. My mother's maiden name was Langdon. What can I say? But we tracked it back. We traced it.
Okay.
Yeah. The kids did not have, 3 heads or anything. They're genetically stable, hopefully. But but I came here on purpose. Same for pediatrics. We talked about this too. I get very frustrated. There is a persistent myth, rumor, stereotype that for medical students like yourself, you're a smart kid. You had high scores. You have good interview skills. You went to Duke or wherever. You will choose the smarter you are. It perfectly correlates with the highest paying subspecialty you could pick. So the super uber elite brilliant kids are obviously going to be neurosurgeons. Right down from that, maybe you'll be cardiothoracic surgeon. Maybe they're tied. Maybe you'll be ophthalmology. Maybe you'll be ENT. Maybe you'll be plastics. Those are the good kids. Those are the smartest kids. Obviously, if you're smartest, you would choose that.
And they
But
also
it pays the
generate
best.
most money.
Generate the most
hospital.
income for themselves and the hospital. Absolutely. That's the best life, right? Okay, and then a little bit down, ortho also very smart. Maybe not with the whole workings of the internal body, but with the bones for sure. And I mean it's true. Like read an EKG, come on, and
Sure.
yeah, and manage your labs, dude. But and then you keep coming down. I had a horrible encounter with an ortho in a rural. I'll tell you that, man. Anyway, and then okay, maybe you're not that bright, but you want to get to surgery super fast. Be OB-GYN because you can be a surgeon in only 4 years, right? And that we used to joke about that. You would choose OB-GYN just because you wanted to be a surgeon the fastest, right? And then you keep going down. If you have low board scores, if you are not so bright, then you're stuck in FM or PEDS. I call BS. I had good grades. I went to Duke on full scholarship. I had good interview skills. I just want to help people for real. I chose pizza on purpose. So I hate and I object that primary care providers must be the bottom of the barrel. They must be in the bottom half of their med school performance. No, we're not. Oh, it just ticks me off. Sometimes we are, but not always. And so I hate the idea that students are forced into primary care because they're not bright enough to do better options. I reject it.
So tell me the positive. What's giving you life from this?
I would never, even if I went back, I wouldn't choose dermatology. I joke because that's what my husband wanted me to choose. And true, I would have made a lot more on air. Our lifestyle would have been better. But then we wouldn't live on the farm with animals. You know, it'd be right here on Langdon Road with all of our family. And I like that. I like being here. The best part is making a difference in a child's life and being a role model for the child. So I would love to challenge anybody out there. Do you have dozens of kids who dress up as a Dr. Halloween and your name's on their name tag? I do. I have some of the sweetest videos, and they're dressed up in their little white doctor coat, and they're like, "Who are you?" This little girl says, "I'm Dr. Langdon." Who else could say that, right? Who dreams of growing up to be an ENT surgeon like when they're 3 years old? Nobody. But they want to be their pediatrician because they love us and they know we love them. That's the best. I also love it. We joke that the only people who really listen to us are first-time parents of a newborn, but they really drink it in when I'm giving them reassurance, hopefully, when I'm giving them advice and guidance and rules about baby feedings and wet diapers and poopy diapers and all the things. They're listening like to my every word. I love it. I want to be able to offer them reassurance. I want to be able to help them breastfeed their baby. I want to be able to encourage them that vaccines are safe and important and critical and life-saving and wonderful and effective. I want to do all the kinds of education I can for them. I want to treat their kids for depression or anxiety if they need it, and to teach them it's not their fault and there's no shame, and meds can help and counseling can help. Best together, both of them. All the things. I want to be a role model. I want to impact their health for a huge life, all the life years away ahead of them.
And I'll offer some encouragement. This is the Dr. Langdon show. But I will offer some vulnerability too on camera. I shared with you that although I am on ortho research here, I'm going into internal medicine.
I'm so proud.
Yeah, because right before I left, I rotated with a rural primary care doctor who ran his practice ownership.
Love it.
So he had control over his patient population, everything that he did. He advocates for his patients. He spends as much time as he wants to. He doesn't have administrators breathing out his neck telling him what he can and cannot do, and he's doing very well for himself.
Love it.
So when I was like, I can take care of patients
On my own terms.
and make a difference,
Yeah.
because I realized I had enough reps. He let me. And this is the gift. This is a blessing of mentorship too.
Yeah.
Is he let me go in and dive into all the issues
I love it.
with people from all different age
Levels.
groups, and you realize how hungry they are for information and help.
And to be listened to.
And you can tell that they
be listened
haven't
to, yeah.
been listened to.
Yes.
They've been, okay, what's going on? Cool. Okay,
Mhm.
cool. All right, so take this medication. All right,
Mhm.
check your blood pressure, please. Don't drink sugar. Bye.
Mhm.
You can tell that's how they've been treated.
Right.
And when you sit there, you're looking them in the eyes and you're listening to their story
I love it.
and you're giving them advice. And even as a student, I didn't think I had that much to offer, but
Oh, yeah.
I did pay attention.
Yes.
I did learn things.
Yes.
And when I was able to share that with them, and then they left telling the doctor, "You've got an excellent apprentice in here."
And they
It
felt
warmed my
heard.
heart.
Yes. Yes.
Oh man, it's
And when they want to see you and the child recognizes you, and some of the kids would call my office Dr. Langdon's house because they just thought,
Dr.
like,
Langdon's
like
house.
elementary school teachers,
Dr.
you know,
Langdon.
yes, they think that the teacher lives in the school. Similarly, they think your pediatrician just lives in the doctor's office, you know.
Yeah.
And when they would ask me college advice for the teens, and oh, I love it. Like to be respected, to be a role model. That means a lot.
That's
doesn't it?
part of you can't admit that's part of why we go into it
Absolutely.
is because we want to be respected. Is
Absolutely.
this okay?
Absolutely. And that may be part of why personally it has been so demoralizing, the rise of the anti-vax movement and now the current administration
Sure, let's get into that.
legitimization of anti-vax sentiment. It speaks to a bigger rejection of experts. You know, why? You anti-vaxxers, do you get on an airplane and tell the pilot that you're going to take over and reroute you because you read something on Google that suddenly you know more about piloting than the pilot does? It kills me. Why did they pick us? Why are they picking on medicine and peds specifically when all we want to do is protect their children? That's the frustrating part. So that loss of respect, that loss of believing, I'm not making this up, I'm not getting kickbacks. Lord have mercy, could I
wish
use
I was getting
kickbacks? Yes, 6 pairs of braces I pay for. I need kickbacks. 6 wisdom teeth surgery. 5. One's not got hers out yet. Inexperienced car insurance for 16-year-old drivers, it'll kill you. You better start saving now. I'm telling you. College expenses these days, unbelievable. I need the kickbacks desperately. I'm doing good work here. Could I get some? No, there are none. There are no kickbacks. And most private practices actually lose a smidge of money on vaccines. So this notion that pediatricians are making millions and millions on vaccines is not only completely inaccurate, it's insulting. We're the least paid. We're the ones doing the work to protect the children in our society, to get herd immunity. It protects everybody, including unborn babies. So if you're going to be pro-life and want to protect the unborn babies, everybody needs to get their rubella vaccine, which is in the MMR. Hello. It just kills me.
Oh, for everybody listening,
Yes.
it's rubella
Yes.
is making a comeback.
Unbelievable. Everything's making
I
a comeback.
saw a family.
They killed
We
them
monitor
babies.
them.
Yeah,
Monitor
sorry.
them. No, it's okay. We monitor them for like 2 weeks
Oh,
in my
scary.
rotation.
Yeah.
Because one kid had symptoms. He was in that
Oh my
cataract
God.
stage.
So scary. And measles is going nuts now. We're about to lose our status as being eliminated in measles. Canada just lost theirs
I heard.
because we've had ongoing rates.
What do you think started all the
I can tell you
anti-vaccines?
very precisely, and it's ironic the timing. So my residency was 95 to 98. This never was on our radar in residency training because the first paper that came out was fraudulent by an adult GI, Andrew Wakefield. We know now what was going on. He was being paid by people who wanted to market a different MMR vaccine. So he was trying to make it look like the current MMR vaccine caused autism. He had only 12 patients in his study.
I read this.
Yeah, he drew blood from his son's friends at a pool party. And this was published in the British journal Lancet in 98. Well, all the co-authors retracted. It was proven to be fraudulent. He lost his medical license, but it was too late. You can make one false claim, and it takes millions and millions and millions of other patients in the studies, and even then we haven't convinced people. We also had, when that first came out, brilliant celebrities like Jenny McCarthy, who was literally a Playboy bunny. No judgment, no shame. But she used the power of her celebrity to advance this anti-vax cause. And that's where I have trouble. She didn't understand randomized controlled trials. She didn't understand confounding factors. She didn't understand t-value or p-value or r-value. None of it. She understood none of it. She's never taken statistics. You think? You think she's taken biostats? I think not. Oh my God. So I just remember at the time thinking, we need our own celebrities. I mean, the only reason I would ever wish to be a celebrity, I don't want people stalking me. I would love to be a celebrity to say, I'm not, I never will be, but I wish I could recruit one, to say, look, I'm a famous person and I love vaccines because they work and they save children's lives and they're effective and they're safe and they're studied and unbelievable now. Pre-marketing, marketing, post-marketing, the number of people in the studies, unbelievable. And these days, you don't have to be an expert. You can have a 10-second reel on TikTok or Insta or anything and do more damage than millions of patients in studies.
Or in our current,
Or our current administration can
Where
change the CDC website.
from 3-hour podcasts into,
Sound bites.
yeah.
Mhm.
Well, he was RFK Jr. I actually listened to the whole podcast with
Couldn't do it.
Rogan, and he made convincing arguments.
And they're completely false. Right. He's very convincing. He said the other day that puberty is 6 years earlier in girls now. No, it's not. We would be referring them to endocrine for an anomaly. No, it's not average. 6 years. He said there's more testosterone in 65-year-old men than 6-year-old boys. Oh no, there's not. Trust me, I know these things. And he could just make these outlandish claims like that pediatricians are making millions and millions of vaccines. No, we are not. That is a lie. That is false. And so now the whole entire CDC has been hijacked, and they changed their very website to say, we can't rule out that vaccines cause autism. Well, if millions of patients are in a study that controls for confounding factors, we kind of can. We can say it's not autism. Oh my goodness. So frustrated. So that was the beginning of it. False
Yeah.
statement,
Okay.
fraudulent data, faked study, but got famous on the whole anti-vax rounds. He did talk shows. He made a big name for himself, this Andrew Wakefield guy, right?
Websites ate it up.
It was crazy.
Because autism. My little brother has Down syndrome and he's autistic, right?
Yeah.
So, it's one of those things where we don't know what causes this
So
to occur.
Right, we don't.
Right? Or do we?
We're close. There are 2 suspicious sites, chromosomal sites. Yeah, we're almost there. We're almost there. So over 85% of cases are explained by genetics. It runs in families. Now that we have better support, these kids are getting therapy. They're getting social skills training. They're dating. You know what happens when you date? Sometimes you make a baby. And they're getting married, and they're having babies and children and families, and they're having fulfilling careers. And the neurodivergent are excelling in medical fields, in all kinds of things.
Yes, they are.
Yes, they are. And so I like to joke that actually autism causes vaccines, because there are a lot of neurodivergent folks in clinics, and, labs who are actually creating some of
And
these
then they're like,
vaccines.
this kid's got autism and he's getting vaccines.
He's going to be super powerful.
So explain to people kind of the time course of autism, just to kind of help round that.
Yes. Oh, yes. Okay.
out.
So first that happened. Also, by the way, before I forget,
Sure.
people in the autism community are also outraged, and I stand with them. Don't you tell me that you would rather your child die of pneumonia or measles or meningitis than to have autism. You are denying that they were made in the image of God. You were denying that they're valuable and have something to offer. You were denying my child's life. Excuse me. That's ridiculous, and I hate it. So,
Even if it did cause,
right.
which it doesn't.
It doesn't, right? But if they were going to die of meningitis
Yeah.
instead, would you rather your kid be dead than have autism? That's the question. How about that? So in 2007, the American Academy of Pediatrics started having all of us general pediatricians do a screening test for autism at the 18-month well check and at the 24-month well check. The screening test is called the MCHAT, the Modified Checklist for Autism in Toddlers.
Yes.
And we do that initially, and then there's a revised and additional follow-up screening we do if they fail that based on the questionnaire. And then if they do, then we typically refer them for a more in-depth evaluation by, say, a behavior and developmental specialist, which is a fellowship after a Peds residency. There's a shortage of those, no surprise. Or they can go through a program like the TEACH program at UNC.
Mm-hmm.
There are a lot of different programs for an official diagnosis. Some people are nervous to get an official diagnosis based on old, long ago stereotypes that if my child's labeled in school, it'll hurt them. It's the opposite now in school. We have people who are trained, special education teachers, to provide accommodations. If that child needs an individualized education plan, an IEP, the pediatrician or doctor signs off on that, but that means the kid's identified, they work with a guidance counselor, may need pull-out time from a traditional mainstream classroom, may need to be in a self-contained classroom to get all specialized stuff. Who knows? But if we can identify them, they can get better therapies. And early identification allows that to happen. And early exposure to therapies improves outcomes. And that's what we're all about. That's why we're doing all these developmental screenings, right? So that was in '07. Add on top of that, that kids are surviving and dating and making more babies. Add on top of that, that in 2013, the DSM-5 changed its criteria for a diagnosis of autism and included, for example, pervasive developmental disorder, included Asperger's syndrome, right?
Mhm.
So all these things are now on a much larger spectrum. It really is autism spectrum disorder.
Yeah, because when
ASD.
and for context, when I grew up, I go into a special needs classroom
Mhm.
to pick up my little brother to walk near the carpool,
Right.
And so from my understanding, autism was a very debilitating disorder.
Absolutely.
And
Right.
as
And
I've
now
grown
it's
up,
on
now that our
spectrum.
spectrum is
Yes.
much
It's
larger,
widened considerably.
a lot of those people are lumped in
Yes.
together.
And so, for example, we see this all the time. Let's say the child is diagnosed and we say it's genetic over 85% of the time. And the parents are thinking, genetic who? What? And so then they go and get evaluated. And what do you know? Their obsession with trains and their. Who knew? Wait, you mean.
My best friend is obsessed with
Who knew? You're on the spectrum too. It's true.
Yeah.
There's no shame. There's no judgment.
He also averts eye contact. It's so weird. I'm just kidding.
So there are a lot of little things we look to identify them early, but it happens even with the kids who got that MCHAT at 18 to 24 months.
Mhm.
If they're mild enough on the spectrum, they could have gotten through that and then got identified later.
Okay.
So between all of those things, no
Yes.
wonder we have so much more. What I like to say is, and I don't think I came up with this, but I love it and I've used it a lot, but if your telescope is better, fancier, stronger, you can see more stars, right? So if your telescope is better, you can see more stars. You can diagnose more kids because you have more highly developed
So,
screen.
so if somebody gets online and says, well, then why are autism rates going up?
We're identifying
We learned this in
more.
school.
We changed.
Better screening.
Absolutely.
Yeah.
Better screenings, more inclusive diagnostic criteria, and it's genetics, and more of them are being born. Because we provided better services from the beginning. So those kids are more socially qualified to have relationships. And that's a good thing. That's a plus.
Well, I think that, I think that answers a lot of people's questions if they have them.
Good.
I hope we can get that message out there.
Yes. And vaccines are safe.
Right.
And vaccines are effective. And I wouldn't be giving all 6 of my kids all their vaccines if I was in on some secret conspiracy, right?
So you have another impactful story about not getting vaccinated and the impact that can have.
Oh, goodness, yes. So I have so many of them. So I have literally personally been the pediatrician for children who died of vaccine-preventable diseases. Okay. So especially in residency, you'll see more of that. And that's where one of my worst stories comes from. And I'll tell you that one. I told you we worked ridiculously in residency. But one sweet thing I do remember is we got to pick if we wanted to work Christmas or New Year's. Now, don't go crazy. We didn't get 2 weeks off or anything. I think we got 3 days for the whole holiday, right? Maybe it was 2. Anyway, one of my years of residency, I was on a picky rotation over the holidays, and I picked to be off on New Year's so I didn't have to work on Christmas Day because I wanted to get it over with. I'd rather and Nathan, our baby at the time, was so young, he didn't know if we opened presents and Santa came on if it was, the exact day or not. So
Right.
anyway, so I was working. We came home to celebrate Christmas around New Year's because I was working Christmas. Well, anyway, I was on call on Christmas Eve itself.
Okay.
And we would hear sometimes chatter from the emergency department in the peds ICU to be prepared something was coming in. And we got one of those calls. They said we've got 2 siblings, 14 and 16-year-old. 14-year-old was a boy, if I'm remembering right. 16-year-old was a girl. They were the only children in this whole family. And they were coming in, of course, both full codes. They're otherwise completely healthy teenage kids, siblings. And they were coming in, getting chest compressions already, trying to get a line in the field as they were driving in. It was such a bad scenario. A lot of times cases like that stop in the emergency room to get stable, and then they send them up to us and pick you. But they knew it would completely paralyze the emergency room. And we did, even at that time, have separate peds and adult ERs, as everyone should. And so they just came straight up to the peds ICU. Full code, simultaneous 2 people On Christmas Eve, only children in the family. So everybody, of course, out of the goodness of their heart, offers to help. The adult code team came to help us. I could just about get tearful thinking about it because it was so kind of them. Of course, the whole Peds code team was there, which is basically the Peds code team lived in the PICU. The Peds ER code team came up to help us because if y'all don't know, doing chest compressions is exhausting. We didn't have all those fancy do it automatically stuff. It was just by hand at the
I
time.
don't like those
Yeah,
things.
and I'm so short you won't laugh. I have to get a stool to do chest compressions anyway. But I just happened to get assigned to the 14-year-old. You should also know I did a million intubations of babies, right? Babies all have teeth. Like doing intubations on people with teeth is disgusting to me, but I can do it. I did it. So I intubated the 14-year-old, had RT, respiratory therapy right beside me. I love those guys. And got him intubated the first attempt. Yay. During active chest compressions, people trying to get lines. I mean, we were going for febrile lines because the kids are dead. I mean, we were going all out. They were on pressor support, which means they were getting medicine like dopamine or dobutamine or whatever to clamp them down to get blood to their brain so they would have something left after we resuscitated them. I didn't have a mask on because we haven't even got to the differential diagnosis. We were just resuscitating 2 dead kids on Christmas Eve. And I was intubated, and that's a high risk. There were respiratory droplets. It's about by the grace of God. We didn't get prophylaxed that I didn't catch this. Unbelievable. Anyway, as we're doing chest compressions, as we're trying to do the math of their fluid boluses and their third space and everywhere getting puffy, their fingertips are turning black. There's petechia coming up their arms, and it's getting purple, like their toes, their fingers are getting black. We coded them for over 2 hours. Like the trash in the room, just the tips off the IV, the central line, this. There's stuff everywhere. Everybody's taking turns doing chest compressions because there's 2 whole codes. It was in this huge room we had with curtains to split them, but we rolled the curtains back. So it was the same family. I've never seen so many people in that room ever because there were all the code teams, there were all the nurse support, there was all pharmacists came to help. Everybody was there, and they both died on Christmas Eve. Every child in the whole family on Christmas Eve. And we figured out, and we were kind of figuring out as it was going on, but with blood cultures and everything, it was overwhelming meningococcal sepsis. We have meningococcal vaccines now.
Yeah.
We didn't then.
Yeah.
And so the idea to me of a parent saying, no, I don't want those vaccines for my children. My children have a strong immune system. These were not immunocompromised kids that died of the overwhelming meningococcal sepsis. They were just normal kids. It doesn't matter if your child has a normal immune system. They can still die of these things. When you had that option, my kids dying a horrible death versus a simple vaccine, and they could have fought that off. They'd have had preformed antibodies to fight that off. They would have never had to die. We give that vaccine at the 11-year-old. Well, is it now? Those kids wouldn't have died now if they had been vaccinated.
And you're not getting kickbacks for making sure those on schedule.
0.
Yeah.
So now this is what some people accuse us of. There are plenty of insurance situations because insurance pays less for a dead kid with a giant resuscitation than they do for a healthy kid. Yes, your insurance wants you to get vaccines. That ought to tell you something because it costs them less because medical care is expensive and you're not as likely to get hospitalized and lengthy resuscitations and pediatric intensive care unit stays. So if the insurance company wants you to get the vaccine because they want to save money because medical care is expensive, that might be a clue. So yes, in giant practices, if you have all these metrics to meet, it's not just vaccines. Did you do a vision screen starting at age 3? Did you do a hearing screen starting at age 4? Did you adequately screen for all the things? Did you give them an asthma action plan? Did you follow asthma guidelines? Like the whole big bucket of things to meet your metrics for a lot of these programs with various insurances. Yes, making sure the kids are vaccinated could include that.
Right.
Yeah.
So educate me. Let me nerd out for a second.
Sure.
What's the best way to communicate to parents the importance of doing these mandatory screenings and whatnot that are beneficial? For people that aren't as good at communicating, can you help coach them up on how to deliver that message in a way that doesn't come off as in the system?
Right.
Like down in their throat.
Right.
You know what I mean?
So part of it is what we were talking about a while ago with autism. We know, we live by this early intervention, physical therapy, speech therapy, occupational therapy, early intervention improves outcomes. So if we have a child who has expressive language delay, they can't say any words by 12 months. They should be at least able to say mama, dada, baba, or papa, or baba, something that's reproducible and they understand the meaning associated with it. And we do a speech evaluation, speech therapy. They could have completely normal language skills by 3 or 4, be fine for kindergarten. That improves their whole academic outcome for the rest of their lives. That changes everything. What if you have a parent who just neglects to get well child care and they don't know their speech delayed? They're going to struggle longer and perhaps never recover. Same for a growth chart. What if we are, we're obsessed with growth charts. And so for the newborns, we need a naked weight. It needs to be accurate. We need an accurate length. We need an accurate head circumference, right? It means everything to us because if something happens, I need to be able to tell. And if I can't trust the numbers of my growth chart, the maddest I've probably ever been, I get now. Frustrated is a better word. Sometimes the most frustrated I've ever been is if I have a newborn and the nurse who they floated to peds, who doesn't usually do peds, let's say this baby had a birth weight of 815. The nurse weighs them in the office and it's 810. That's not bad. It's just 5 ounces down. Newborns lose down with their birth weight. They gain back by 2 weeks. As long as they're back to birth weight by 10 to 14 days, we're happy, right? But instead of putting 810 in the chart, the nurse puts 8.1. 0.1 is very different than 10/16. 0.1's bad enough. They might need to go back to the hospital for some IV fluids. I might have to supplement with formula even though I don't want to. I'm waiting on our breast milk to come in. It freaks me out. Anyway, that was an aside. Growth charts matter. If they're falling off the growth chart, something bad is happening. So if you're not getting routine well visits, how am I going to know they're falling off the growth chart? I don't have any measurements that are accurate on there to know, oh, they might have renal tubular acidosis. I don't know. They might have some weird. I need to figure it out. I need to do some screening labs, right? So if I don't have any proper measurements, I don't know. If I don't have any screenings, and we think of development in streams. A lot of people think, my kid walked at 10 months, they're going to go to Harvard, right? No, 2 different things. Walking is gross motor. There's also fine motor, like pincer grasp by 9 months. There's expressive language. There's receptive language, understanding versus getting it out there. There's social. There's personal social. There's problem solving. So there are all these different streams of development. And typically, there's a specialist associated with them. So if you're behind in gross motor, you see physical therapy. Y'all know PTs are doctors. They are doctorates of physical therapy. They're smart people. I use them as consults, not just to provide the therapy, but help me figure out what the heck's going on with this kid with their weird gait or whatever. They're wonderful, resources to have. Even rural areas usually have PT. Love PT. And a lot of them specialize in kids, which I love. So if they have a failure of or lack of development in fine motor, we refer them to occupational therapy. Shout out to OT, by the way. OTs across the world have it's just a miraculous thing that happened, taken on autism under their umbrella. They do everything with kids with autism. They can even help with texture aversion, and like with some speech therapy can do that too sometimes, but OT will take over all kind of aversions, learning how to live with a tag in your clothes or whatever it is. I just cut them out personally, and I don't even have autism. I hate tags. But so they will help them deal with things so they can have better outcomes. So anyway, lots of streams of development. And if you are missing on those developmental assessments, I do an ages and stages questionnaire from the 2-month well check through the 60-month or 5-year-old well check. At any of those ages, if there's a problem, I'm either going to talk to them about what to do to make them overcome that delay, or go ahead and refer them and follow it along to the next well child check. You can miss a lot of very important screenings, growth measurements, and anticipatory guidance. Remember, at those well visits, we're telling you, this is what's about to happen now. You need to get swimming lessons, for example, because the #1 cause of death in the United States from ages 1 to 4 is drowning. So if they didn't hear that from us, maybe they didn't even think about they needed to get their kids swimming lessons. Or, I know you think your kid is big, but I'd rather them bend their knees and stay rear facing and save a head injury. Leave them rear facing for as long as you can in the car seat. Whatever. We have a lot of anticipatory guidance to offer. Ticks, sunscreen, all the things. And so if you're missing that, you're missing the chance to learn about how you can best keep your kids safe.
Okay. So how do you approach the vaccine conversation?
It is important, even in this
Like if
arena.
you, especially, sorry,
Right.
if you feel, you can kind of get a vibe sometimes. I go
Sure.
to patient rooms where it's like, I don't know if they're going to be very receptive to the fact I got to give them like 2 or 3 shots today.
Right. So I start out with a presumption, not permission. That's recommended by the AAP, for example. So that is, Your sweet baby is due today. I am so excited. They are going to get 2 injections today and a little liquid by mouth at this 2-month checkup. You remember they've already gotten a vaccine when they were born, Hep B, so this isn't their first vaccines. It's just their first set of vaccines. The reason I'm excited is now I am not quite so nervous because they're going to already start building antibodies against all these diseases we're protecting them from. So this is a really important day.
And that's how you deliver it.
Yep.
Legit. Okay.
Yeah. So the liquid by mouth, sometimes they'll
Yeah.
spit it out a little bit. Maybe it doesn't taste great, but it's not terrible. And some of them suck it down and love it and just smile and licking their lips. And then the 2 little injections, it'll be really quick and we'll hold them very still. It'll be in their thighs. Sometimes afterward, they can get a little bit of a pink mark around there, and that's okay. They may be cranky if their legs are sore, but usually they're fine. If they got a very high fever, which I don't expect, these are very safe, it would be okay to use some baby Tylenol. Let me get you that dose. Now, we don't use ibuprofen until 6 months. They don't get any more vaccines till you guys come back for your next regularly scheduled checkup at the 4-month visit. This is called their primary series, 2, 4, and 6 months. They'll get the exact same vaccines at all 3 of those and be completely protected for this age group.
So you're an active educator, and that's the presumption, not permission.
And
I love that.
Yeah.
Yeah, I love that.
And then if they say, we especially use that in the adolescent well visit. So for the 11-year-old well check, they're due to get Tdap, tetanus, diphtheria, and acellular pertussis, and a meningococcal vaccine. There's different brand names, Memquathi, Menactra, it's ACWY. And then Gardasil to protect against HPV. For some unclear reason, Gardasil has been unfairly attacked by a lot of people and demonized by like testimonials on Facebook. And remember, anecdotes are not science. Anecdotes are individual stories that could have been modified, might not even be true, and certainly don't impact actual numbers, So Gardasil is amazing. Gardasil protects against not only cervical cancer, but penile cancer, perirectal cancer, all the head and neck cancers. Is incredible. Well, anyway, this is what's happened to me for years multiple times. This is back to that permission versus presumption. I'll have a nurse. I say nurse.
Yeah.
Some health systems. Does it pay for nurses? I have MAs. Anyway, so maybe you get an MA who's not big on the Gardasil vaccine for unclear reasons. She read something on Facebook, right? She walks into the room and she says, "Okay, Johnny, you're due today for 2 shots. They're required for school, Tdap and Menactra, for example. And and there's another one. There's a third one if you want it that you don't have to get that. That one's not required. I've had that happen to me millions of times. Pisses me off. And we have done studies that prove the presumption versus permission. We have done all kinds, but the hard part is when the rubber meets the road, it's that individual staff member that has to be educated. And then I'm not in the room with him every time they watch in.
And
It's staff education. That's exactly right. That's exactly right. And so many parents, when you educate them, because a lot of them honestly thought it was just for girls because it was developed for cervical cancer. But then we realized the very same strains that cause cervical cancer cause all the boy part cancer and all the head and neck cancer, right? It's fantastic. One of the best breakthroughs in medicine. Literally cures cancer because it prevents it. And so I'll have parents and I'll tease them when they turn it down. I'm trying to keep it all happy and light, right? No reason for them to hate me or shoot me because everybody around here has guns. And so... And so I'll say, well, you guys, let me just ask you, did you ever do some of those American Cancer Society walkathons, benefits, fundraisers? Oh, yeah, we love it. We have a booth and we raise money for them. Fantastic. Guess what you were raising money for to help prevent cancer? Guess what? It worked. We have a prevention for cancer right here. It can help your daughter from getting cervical cancer, and that's no light thing. And the girl will say maybe, or the boy, well, I don't like needles. Yeah, well, guess what? When you get cancer, you have so many more needles than I have for you today. This is just one. When you get cancer, you get IVs and central lines and chemo and cryotherapy and surgery.
Have you had to do that? Have you had to say?
Oh, yeah. 100 million times. Yep. And they say, well, we thank you for telling us, but we don't want it and we'll never get it because we know it's the work of the devil. Okie dokie then. And then I shut up. And you will sometimes just hit a brick wall because a lot of persistent anti-vaxxers have a fixed delusion. They're done. For example, they interviewed, and I'm not reaching him, but she wasn't my patient. It was a Texas patient, a 6-year-old little girl who died from measles. Do you know what her dad said in the television interview? At least we didn't give her that vaccine. They don't get it. They don't understand it. They'll never understand it. For those, not everybody, most parents understand vaccines are important. They're just nervous because of all the crap on the social media. But the ones that are the ones sharing the misinformation, sharing the disinformation, And the difference with mis and dis, mis is, oh, I didn't know it was wrong. I just shared it. I kind of thought it was a good post, so I shared it. Disinformation is RFK Jr. Disinformation is people who know this is a lie and share it anyway and hurt people. Anyway, and so they have seen enough of that they're nervous. They want to trust me and they like me as a person because we go to church together, but and we see each other at Walmart all the time, but they've just heard all the bad stuff. And so they're scared. And so they're very nervous. And some of them, and I hate it, they'll get the vaccine, but they'll go home and cry because they're so scared something bad's going to happen to their baby. And I want to save them from that crying. You don't have to do that. Oh, makes me sad. But yes, I do try to gently understand. Well, share with me a little bit. What are you worried about the vaccines?
Yeah.
And not a funny story, but it was a story, all right. I was in a practice one time. I 100% agreed with this. We had a baby in the waiting room. And a family who was one of those fixed 0 vaccines for any of the kids' families. One of their kids had pertussis, unbeknownst to us at the time. Coughed on this tiny newborn baby. Tiny newborn baby got pertussis because they haven't had a chance to get their first vaccines yet. And their mom's immunity may have waned. Because they do get IgG to cross placenta, And for some things, that'll persist till 6 months and they get some coverage. But not if mom's immunity has waned. Well, anyway, so this baby caught it. They were in the peds ICU. They did not die, but they were extremely sick for a while. It was terrifying.
Yeah.
Anyway, that's when this practice had to start thinking about, are we going to allow patients who are 100% opposed to any single vaccine to stay in the practice? And we had meetings and meetings and meetings and meetings. Because the AAP still said, keep them so you can keep offering them every time. And I get that, but there's the harsh reality of, we kind of hurt that baby by not having a policy and the baby was in our waiting room. We don't want to hurt a baby. We want to protect the baby. So we did develop a policy and we were very generous about, if you'll just get basically 1 a year, you can stay in the practice, but you can't 100% refuse all of them and still stay here. It's dangerous. Anyway, well, after we got that policy, I was seeing maybe a 6-month-old and we didn't have their records yet, their first office visit.
Yeah.
And I said in my very thorough obsessive compulsive history taking, as I do, they laugh at me in the health center now because I start with these 20-year-olds like, so were you a preemie or full-term baby? I don't know. So I don't have the parents there to give their history. Anyway, and I was asking her if the baby's immunizations were up to date because I didn't have their records yet. They just hadn't transferred yet. And she said, absolutely not. And I said, oh, well, that's going to be a problem then because actually this practice has a policy that we do require vaccines to stay with our practice. I'll still, of course, see you today and provide the very best care I can. And she had already mentioned that she had 2 older kids in public school. And I said, well, your older kids must be vaccinated then if they're in public school. And she said, no, they're not. In North Carolina, all you have to do is check religious exemption. And I said, oh. And I was feeling sassy that day. The older I get, the more my filter is just wearing out, I swear. Had a few examples of that. And so I said, well, you know what, man? I personally love vaccines. I have done training. I did my published research is at vaccines. But I'm also relatively well-versed in scripture, it turns out. And I am. I can still quote chapters. Don't worry. And I said,
Don't doubt it.
you know what I have always wondered about? I have always wondered about a reference for religious folks refusing vaccines. If you would not mind just sharing with me, I don't know, just the chapter and the verse, and I'll look at it myself. I might already know. If you could just explain to me how your faith impacts your vaccine refusal. Because if you're pro-life with your faith, as some people are, it keeps children alive. So, I kind of think pro-vaccine and pro-life kind of go together. I was just curious. And she said, I don't believe in your Bible, and I don't believe in your vaccines. I don't believe in Jesus or science. And I was like, crushes it. But I have a t-shirt that says, I love Jesus and science. And of course I do. It's hanging in my office at the med school. And I said, oh, well then, I'm so sorry, ma'am. I don't understand. You said that you were, well then which religion is it? You're the one that said you checked the religious box. She said, I don't have religion. I'm an atheist. I just want the dang vaccines. Oh.
Okay.
So these,
All right.
And the thing is, I had tried years ago to try to make a motion in the state Senate to say, could we just change the wording to non-medical exemption? Non-medical, not religious. Because people hear religious and have this knee-jerk reaction. Let me grab my gun. Don't you attack my religion, right? And so, but it's not even religion. She admitted it to me. It wasn't religion. She was an atheist. So she rejected all the things I care the most about. Jesus and science, all in one sentence. I don't care about your Bible or your science. Lord have mercy. Anyway, the other example, if I may be so bold, of while losing my filter through the years, and this was also relatively recent.
Yeah.
Had this newborn baby,
Okay.
seen it for a weight check, reeked of marijuana smoke. I shouldn't even know what marijuana smoke smells like. I grew up in a cult and got married when I was 19. I'd never smoked weed. I'd never been around people who smoked weed, except for patients.
Yeah.
And so, anyway, but I do know just from newborns reeking of marijuana smoke. And I had, of course, at the initial office visit said, does anyone smoke in your home around the baby? Because we know exposure to secondhand tobacco smoke drastically increases risk of SIDS, sudden death syndrome, in babies. So we feel passionately about smoke. Saw the baby again and again. Finally, whatever visit this was, I finally said, ma'am, I am so sorry, but the baby's car seat smells like marijuana, and I just sniffed the baby's hair. The baby's hair smells like marijuana, and your diaper bag smells like marijuana. And I had asked you about marijuana use around the baby, and you said no. So I just got to ask you, do y'all have like a marijuana smelling candle or something? Because I know what it smells like. Do you know what she finally said? She was laughing. She said, no, ma'am, you asked us if we smoked in the house. We smoke in the car, which is worse. It's a more concentrated exposure for the baby. Like I felt like I was getting a secondary high from smelling the baby's hair. I was so ticked off. I was like, oh, no, ma'am, you misunderstood. I don't want anybody smoking around this baby anywhere,
The baby was
especially in the car. Oh, that baby was chilling all right. Good gracious.
sad though.
So sad. It makes me so mad. And I used to get so frustrated because stuff like that, when I was young and naive and stupid, I used to call Child Protective Services over. They don't care. They don't have the facilities. They don't have the staff. They're not needing people. I just mean they don't have the ability to respond to everybody who's smoking weed around their baby. Ugh, makes me so mad.
Well,
Take the babies. Take care.
well, moving over to since we just talked about education, I want to bridge over into your academic pursuits. How did you get involved in academics at
Crazy
Campbell?
story. I would have never done this. So the large practice I was with at one point was micromanaging, super high quality practice. Still love them. Lots of friends there. Great qualities. Many of the people I know here, even at Campbell, go to this practice for their care. The way I got into academic medicine, which is wild. Again, I went to Duke. That's the only academic thing I've got on my CV. Except that I have always had medical students. So I have had UNC medical students when I was at that small practice where I was a partner. I've had medical students from UNC when I was at that large practice. Lots of practices I've had medical students for years, which it turned out to be absolutely essential because I had to have some sort of academic background to even apply for my current position as chair of pediatrics. So I was at a smaller hospital and practice local to Campbell. I started it, one in Lillington. And I've known Dr. Chris Stewart for years because he's also from Harnett County. And
Dr. Stewart.
yes, Campbell at the time had lost its chair of peds because she went on to be a dean at another school. And he is the course director for cardiology. So he called me because there were 2 sweet little peds cardiology lectures. And he didn't have anybody to give him. He just didn't happen to be friends with peds cardiologists. They exist. Not in Harnett County, of course. But he just didn't happen to know any. And he thought, hey, I wonder if she'd do this. He called me and I said, well, that is an intriguing thought. Let me consider that. And then I thought, do I have to make the PowerPoints from scratch? That's going to take me years because I'm not an IT whiz, I promise. And he said, oh, I've already got the PowerPoints. I'll email them to you. See if you think you can do it. And ironically enough, the former chair of peds was a terrible speller. And I got these, oh my gosh, do I have permission to change them? And I was too nervous to at first. So I did that first lecture with some typos, some misspelled words, which drove me crazy because I'm a grammar Nazi. And finally, I was like, oh, wait, I can do this. I can change this. She's gone. She won't know. And the words are misspelled. I know how to spell these words. And I loved it. And at the time, we still had mandatory attendance for didactic lectures in the auditorium. And it felt like I have found my calling. These students are gorgeous. They're the age of my adult children. They're smart. They're kind.
I will say,
They're
what do you think about?
listening.
I think DO students
Are better looking.
better looking.
I don't know about that. Maybe. I don't know. It's a possibility.
The classes
I don't know.
it's a rumor.
That's
So I
a
apologize.
great rumor. I don't know, but they were pretty good looking. And they were all in the audience. They were listening. They were watching me. They were paying attention. They asked appropriate questions, which kept me more engaged, giving the lecture. I loved it. Well, then he must have shared my name with somebody else because I got another call to do another Then I think the next thing I got to do was the congenital anomalies and dysmorphisms lecture, which is a pathology lecture, also a 2-parter.
Yes.
I love that lecture. I just gave it recently, again, like for the 4th time, maybe.
Yeah. Good lecture.
I love it. And so I got to keep giving more and more, and I liked it. And I'm burned to a crisp, if you couldn't tell from our prior discussions. And I was like, academia. I bet they have like regular schedules. I bet nobody vomits on them. I bet nobody pees on them. I bet they get to go home at a normal time and nobody calls them. So anyway, I was thinking back of all my horrible pictures and rashes and texts and poop all the time. And the poop calls. They call all the time for poop. I've been called in the middle of the night because a 9-month-old baby's poop was brown.
Dr. Fran, the pediatric GI doctor, he said constipation is the biggest issue.
Oh, it absolutely
Facing-
is. Absolutely is. And I can't remember if I had, when you got my PhDI lecture, I don't know if I had done this, but I now have a slide in my PhDI lecture
Mhm.
that is the guy from Pirates of the Caribbean. What's the main guy? You know.
Jack Sparrow.
Yeah, Jack Sparrow.
Yeah.
And it's a meme that says, if rum doesn't fix your problems, you didn't use enough rum. So I took that meme, put it on the slide, and right beside of it, I said, it's the same with Miralax. So
Yes, you did.
Yes,
It really is.
so if your kid is constipated and you cannot break through, you're just not using enough. I have recommended, 8, 10 capsules, like a clean out, basically, like a pre-colonoscopy, go lightly clean out with Miralax. Anyway, so back to how I gotten. I love the lectures. I love the intellectual stimulation of relearning all this stuff from medical school and teaching it to medical students. And as you can tell, I'm packed with amusing and clinically relevant anecdotes. And so I could just throw them in there. And my student evaluations, which admin actually reads, which is funny to me, were always like amazing anecdotes, love the funny stories, makes it real, makes me remember I'm actually in medical school. I'm going to get to see real patients one day. All that, which I love. That's what I'm here for, right? And so I can remember even though Duke is super academically elevated and competitive, the Harvard of the South and all that. I get it. And I love it. But I really do specifically remember we once had a genetics lecture more than once, one of our genetics professors who gave lectures only about his current research. We didn't understand it. And we were going to have to take boards on regular genetic stuff. We needed the lectures on the regular stuff that was going to be on boards, that was real lived experience in rural primary care, which is our mission statement at our school. And so I thought, hey, I'm not qualified to do this, but I'm doing it and they like it. And it's the material that's on the boards and they're passing the boards. I'm going to do this. So I decided to apply to be the chair of peds at our medical school.
So you applied.
So it's a whole application process. And the position had been unfilled for a year. So it's not like anybody was beating down the door.
Yeah.
You know what I mean?
Yeah.
Because again, we're in a rural area. Who wants to live here? And the funny thing is, for our medical school is, I already live here, man. I don't like Langdon. Exactly. I'm 7 miles from the medical school. It's insane. And what's funny too is a lot of our professors actually don't live here. They live in Holly Springs and Fuquay, which is fine. But it's just funny. I'm literally already here in rural primary care.
You're the poster child for our school.
Absolutely. We're supposed to be producing physicians who want to do what I've just done for 30 years.
Have you been successful in converting a lot of?
So we have had well, first of all, our match rate for peds is 100% every year. Fabulous. Like many times first choice. Competitive programs too. We've got people at not only all 5 programs in North Carolina, which UNC Duke, these are competitive places, but also National Children's in DC. We've got this past year, I didn't tell you this, the first time QSOM has ever had a Harvard match. That's me. So a child neuro last year matched Harvard. I wrote that LOR, Ashton Patel. Yep. And she said it was fine to talk about it as a praise through the school and everything. But oh yeah. We matched to Harvard. I love it.
That's awesome.
That's peds.
That's awesome.
So our numbers were slightly down this year. Last year we had 21 that went into either peds, med peds, or child neuro total. And that's pretty good. It's more than it's been in some years past. Well, anyway, that's probably an all-time high, 21, 22. This year it's 17.
What have you seen?
Oh, nationwide, it's way down, especially allopathic schools, way down. So, when we really became scared, another reason I wrote the book, lots of reasons.
Yeah.
Tell your stories about vaccines, tell your stories about rural medicine. But the match before this past year, so this past year, 25, there were still unfilled slots in pediatric residencies. My best guess from just looking at it after the match was around 150. But the year before that, it was 250 unmatched slots in peds residencies. That's horrible. We already have actively this minute have a pediatrician shortage. We have a projection for a worsening pediatrician shortage. That was before this. And then 250 unmatched slots. It's horrible. So we got a shortage.
And so your entire, because one of my questions was going to be, how does that, you hear it floating around in the headlines, we're having a doctor shortage, we're having a shortage. What does that look like? That looks like
You're doing everything by yourself and nobody else will take call with you. Yes. And that looks like you're going to Everstat C-section. And that looks like we need more family medicine docs to provide high quality pediatric care, which can be an issue. And we need more APPs to go into peds. And we need to be able to recruit people to rural peds. We just need people to choose to do pediatrics.
So what would you say to people to convert over into pediatrics? If they're on the fence, they don't know, they love the patients.
Yes.
They love their rotations if you're talking to a student, but they're hearing the drawbacks,
Right.
which are innumerable.
Right. First of all, if you're a student, and we're being real, right? I can be honest.
Yeah.
It's easy to match into peds. If you're a DO student, and DOs are doing great with peds match right now, but as far as even the percentage of upcoming peds in training increasing proportionately DOs, you can match. We had a whole policy statement the summer of 2024 after that horrible match from all the powers that be. Future Peds Res is the Instagram page for people interested in being pediatricians. COMSET, the Council on Medical Student Education and Pediatrics, the American Pediatric Chair Group, the American Academy of Peds, all the people, all the powers to be, released a whole beautiful policy statement that said none of the pediatric programs, the residency directors, expect DO students to take USMLE. You only need COMLEX. We love to see research, but we don't have to. So if you are nervous about your chances of matching, for example, if you have a history of a board failure, I'm not saying give me your dregs. I want high quality people who are going to love these children who are smart and brilliant. I'm just saying, if you're nervous, you can match in peds these days because we need your help and there's a big shortage. And then we'll teach you to do great at it and follow guidelines and practice high quality. Yeah. It's a whole different set of differential diagnoses. I hate it.
This is a field, I want to say it. This is a field, if we're making a sales pitch for peds.
Yes.
This is a field where, while on paper, you're not passionate about research, so you didn't do a lot of research. Okay. You're not good at standardized exams because they are a beast in and of themselves. And you didn't do well, but you love taking care of people and changing people's lives.
This is your
career.
Yeah. It also, if you truly believe in advocacy, I do, but I've been trained to through the North Carolina Pediatric Society and the American Academy of Pediatrics. We band together and we can accomplish more. We can encourage one another. Like I was telling you about, we have a yearly annual meeting for the North Carolina Pediatric Society, and they've been so kind to include me as a chair at a DO school, the only DO school in our state, and we have chair panels every year at those meetings. So I know program directors, they know I have good students. Our students get into all their programs. It's a beautiful, reinforcing, self-fulfilling. It's wonderful. It's just been a beautiful thing. And so that particular meeting, it was a little sad though, because we're facing the problems with vaccines or child trauma with immigration policies, Medicaid cuts, all the things. It's a rough time for pediatricians right now in some things. That's going to get better. And we have ideas and we have committees and we have programs to try to improve the shortages in peds. You will make a bigger difference in life years than you could do it anywhere else. You will never feel like I could have done more good in another line of work. No. You have no better place to do your advocacy than to help children because they don't have a voice for themselves. You're the person who could save that child from an abusive situation by recognizing the signs. It's just, you have so much potential to make a difference in their lives and to advocate, which I just think it's almost like a quality of character to me, is to be willing to step out to represent children. Go to White Coat Wednesday at the legislator and tell them.
There's a White Coat Wednesday?
Yes. So the NCP Society sponsors White Coat Wednesday once a year at least, but we also have our own lobbyists to try to help with issues that pertain to children, like vaccines, like Medicaid cuts, all of those things. We really do.
So there is a force going
We're
into
trying.
policy making.
Yes, absolutely.
Vaccinations.
Absolutely.
Dude, heck yeah.
We love,
I didn't know about
yes,
that.
absolutely. And the AAP has always done that on a national level.
Mhm.
And NCPs is super strong, one of the strong chapters within the AAP to encourage each other. I'm also on right now. So there's a committee within the NCP. It's, I can't say no, I'm on every committee. But one of the committees, they jokingly call it the brain trust, but it's really the workforce issue committee. And we're trying to just brainstorm through ways of encouraging students to choose peds. And so I always have a welcome back to school party at my house. And this year I had the CMDA students, because I'm faculty advisor for that too, and all the peds potential kids in the peds club, students in the peds club who potentially wanted to peds. Sometimes they change their mind. It makes me sad. So these are just generally first and second years, mostly second years at this time because it was early in the year. But the NC Peds Society sent people to here just to meet the students and say, what would you guys like? What could we do to encourage you to choose peds? Wasn't that sweet? And they've already done it. They had recently on November 11th, they had a whole online meeting by Zoom of representatives from all 5 peds programs in North Carolina, residents from all of them, answering real life questions from students. Was life like in residency? Why'd you choose peds? Why'd you choose this particular program? And also we had the most students at that NC Peds Society from QSOM than any of the other medical schools in North Carolina. And they got to meet a lot of residents, and because there's a residency poster presentation as a part of that whole weekend, it's an extended weekend. And so they got to talk one-on-one with some of these different programs and decide where they might want to apply. Isn't that awesome?
That is amazing.
That is really good.
Yeah. And that's kind of why we're doing this.
Good.
Is because it seems like students and trainees really respond to hearing voices from the other side.
Yes.
From the future.
Right.
Like all they hear is usually from their other students telling them, oh, you don't want to do that. You won't make a lot of money. Like, oh my gosh. But when you see somebody who's fought through the best and the worst of this field and is still telling you, I would not change it. That tells you something.
Absolutely. It's worth it. Nothing that you could have done for a child was wasted.
And it's not worth it because of, like you have an amazing house, an amazing land, all that stuff.
Right. We're not wealthy, but we're very comfortable. We're fine. Yeah. And then nobody can ever accuse me if you just became a doctor to be rich. Nope. I didn't. You know what I mean?
Exactly. Yeah.
Or the other thing I think about, some people say, well, I could have gone to medical school. And but I did. And you should, if you could, because you could help people.
Right.
You know what I mean?
Yeah.
Oh, there was one more story I was going to share with you.
Okay.
I mean, you can ask all the stories you want. I would talk forever. So when I was a 4th year medical student at Duke, I had Nathan, our oldest. He's 31 now, because we recently had our 30th med school reunion, which is so weird. That's another story. But I had 0 resources, no support. People thought I was crazy. I was just paranoid all my eggs were going to dry up. I don't know why, because I love kids. I always knew I wanted a bunch of kids. And so we had him on purpose, intentionally, so I could deliver in between like this boards and those residency interviews and all that. It was very, very well timed down to the exact month, and we were blessed to do that. Well, now as faculty and chair of peds, I have come up with a whole new idea. Somebody else had the original idea. I just made it happen here. It happens already at a handful of med schools, both allopathic and osteopathic across America.
Yeah.
But here's the plan. If you are a 3rd or a 4th year medical student and you have a brand new newborn baby, you can sign up for, we call it, newborn caregiver medical selective. You could be the mom or the dad. You just have to be a 3rd or 4th year. It's 4 weeks. You will have given assignments. These are all posted on New Innovations. And you have to read, for example, about the evaluation of a well-appearing febrile neonate. So you'll learn why not to take your newborn out in public and catch germs. You learn about local resources. You learn about childcare availability and how that impacts local economy and ability of women to return to work. You learn, you have to watch all the breastfeeding modules. You have to watch how to do a newborn physical examination. There's all sorts of stuff. You do reflective writing. You keep track of your baby's intake and output data or developmental milestones. All sorts of assignments are on there. There's a Qualtrics pre-survey, post-survey to help QI improve the course as we go. It's an independent study. 4 weeks, you get full credit for a clinical rotation. So it feels very full circle for me because I didn't have that support. And we currently have our very first student doing it. So I had to present it to the Dean's Council. It passed. Then present it to the curriculum committee, and it passed. And it really doesn't cost the school very much. anything.
Yeah.
So it's really just to help students. And I hope it can help attract students who have that goal of having
Wait.
babies.
Yeah. So again, just so I'm absolutely clear,
Mhm.
is it the student, if they have a newborn baby, they can do the rotation?
Whether it's the dad or the mom, adopted or new or biological,
Okay.
as long as it's a newborn.
So
It wouldn't
that-
really work if it was a teenager. It has to
So
be.
it's a little bit of a great opportunity.
Yeah,
See if somebody,
it's all by Zoom. When they meet with me, they're willing. They're
you can plan too, like if you were
yes,
gonna give
so
that
you
to
do
or-
in
yes.
right. It's a beautiful thing. I love it.
Let's create.
Thank you.
Let's see it.
And it actually worked out. I give Dr. Agnell a hard time because he talks me into doing things like working on NBOME. So I write board questions now for Complex
You're
and COMAT.
responsible.
Yeah. And so it was, I met a psychiatrist. We were at the same table for dinner one night at one of these assessment item writing. They don't call them questions. Assessment item writing weekends. And she told me about this. She's at University of Incarnate Word in San Antonio, Texas.
Yeah.
And they have this. And so she shared her curriculum, the syllabus with me. And then I got a few more. I talked to some various things. They're doing this and just saying its praises. And there were testimonials from students and all that. That's what got me started thinking about it. But it took a minute to get it all together. And then I had to map out
your homework.
Oh, so much homework. And then I had to map out the core competencies to the individual assignments week by week and come up with the grading chart and all those things. But it's working. We have a student doing it. And she came by the office yesterday afternoon with her 3-week-old baby and her husband. And I got to hold the newborn baby. It's wonderful. So very excited. It's the best thing I've done in a long time.
That's such a blessing.
Well, it might be another good thing I got. Now that I'm the director of the Campbell University Health Center, we could never dispense oral contraceptives there. Did you know that? In the pharmacy at a student health center? We can now.
I'm always seeing.
I write an email. It is standard. Prior director said it just wasn't a battle. He thought it was appropriate for him to fight. Anyway, I felt it was a battle appropriate for me to fight, and I fought it, and I got it.
It's very appropriate.
Yes, it is.
Rural.
Okay, no, really? Kidding me? And we talked about a while ago, sometimes there's this sense of if there's something I cannot do, it's like that forbidden fruit that you really want to do it. So you got all these Baptist kids coming to college, and we know we have a high STI rate. That might not be good information to release, but anyway, we do. So the kids are doing the things. And so if we want the females to be able to stay in college, not pregnant, be handy. And some of them don't have transportation, so we needed it. It was a very necessary, important thing to do. But also, as you know, we medically use it for so many things. Polycystic ovarian syndrome, premenstrual dysphoric disorder, endometriosis. There are a host of medical indications regardless.
Aside from
Right,
pregnancy.
right. And despite that, we still couldn't dispense them. But we can now. So those are probably that and defending the use of fluoride public water sources in Harnett County are probably my biggest wins this year. Yeah.
Congratulations.
Thank you. So I'm the vice chair of the Board of Health. Well, that's the other reason. If you're a rural doc, you kind of got to just do all the things. You got to be a part of the whole community.
Now that is an opportunity
yes.
for crazy people like
Yes, we just
like
go
us.
for it.
We're like,
Right.
what can I get into?
What's
with my-
more work? What's more?
Yes.
Yeah.
I want to help people.
Yes.
Well, we got a whole lot of work for you to do out
It's
here.
true. At the Board of Health, always there's work to
Yeah.
do. But it is good, since I believe in advocacy, it's good to be on the Board of Health to get to do those things, because we have in this county, a very poor county, rural, we have not enough dentists, not a surprise. We have only one pediatric dentist, and most children with complex dental needs, dental caries, like the ones that need complete restoration, they need conscious sedation. We don't have facilities here to do that. So that means they need transportation. So the last thing we need to do is remove fluoride from our public water sources and increase our rates of decay. And dental caries are a big public health issue for poor children, especially rural in North Carolina.
Yeah.
That and obesity and now mental health.
I think
Those are the three big things.
it's a business opportunity, kind of sounds like, for somebody, if they were willing to commute to their practice out here. They'd have a lot of
We have one. There's one practice in Dunn that sees kids now, and that's relatively new, just for a couple of years, but and we're grateful for it.
Yeah. Okay, so we've talked for a very long time, and we can clearly, I don't know,
So fun.
I know, and we could talk for so much longer.
You can make multiple episodes.
But that's what I'm saying.
I don't care.
Here's my idea.
Go change my shirt, make you look so different.
Coffee will come back
Yeah, that's right. Hit it again.
all night.
Yeah.
Okay. My idea is that we have opened up so many cans of worms. There's so many I could have seen down.
Yes.
And one of the things I wanted to tackle, but I don't think we have time for today, is mental health and children care. But I think if we both go rest up,
Sure.
would
We
you
can Zoom
be
in or
willing
something or
to
come-
zoom in
Yeah.
and we have a dedicated conversation
Sure.
just
Just
that?
about mental health. Sure.
I think
Sure.
that'll be beneficial. How do you feel?
Absolutely. Absolutely.
Okay.
No, and we have a little progress here. So thanks to our senator's assistance, we're building an inpatient 16-bed behavioral health unit in Harnett County for under 18-year-old. It's not open yet. The ribbon cutting should be the end of March. I should be able to be there because I'm on the foundation, the charitable support for that.
That's huge.
Of course I am. And yes, and that means that they'll have to bring in a child psychiatrist to run it, and he's supposed to have office hours, and they are actively recruiting him right now. Them, he, she, him, her. So I'm very excited about that. Yes, and I hope to send them a ton of my undergrad students because I'm doing stuff right now that's on, I'm liability averse, and I'm nervous about managing some of this stuff. I'd love to have a local psychiatrist who could see like adolescents
Oh, so you're the only one responsible for mental health issues in
and
the
students.
undergraduate student?
So I'm prescribing all the things.
Well, we'll dive into that next time.
That's exactly right. Stay tuned.
Stay
yes,
tuned.
absolutely.
Well, Dr. Langdon, it's been a lot of fun.
Yes,
Thank you
this was
so much for
great.
letting me to come hang out. This was awesome.
And there's so many more stories. So yeah.
Well,
We'll just do
everybody,
away.
if you want to know more,
Oh, there you go.
look,
Thank you, please. Yes.
doctor working in air
Yes, yes,
conditioning. It is
yes.
pediatric medicine. What would be
It
your
is.
sales pitch?
So this would be great for anybody who loves to read like
Yeah.
gossipy stories about real life medical scenarios that happened, HIPAA compliant, or if you have a loved one in your life who wants to pursue medicine, give them this for Christmas, please. Or if you have a policymaker, House of Representatives, senator, and they're making healthcare policy, I really wish they would read this.
Or at least share the stories that are inside this.
Yes,
Say, well, I've heard about this,
This
and it may
issue.
dig into it more. And then
Absolutely.
I've been on a rabbit hole a lot lately because all it took was one article.
Gotcha,
And
interesting.
I'm like, this,
It
a
matters.
lot of issues.
Yes, yes. This could be good for kids or students in getting their Masters of Public Health. Any of those students, I think, would be interested in this. So really good for anybody. People from the South who have like those nostalgic feelings of growing up on a tobacco farm. I hated it. My husband loved it. Who can understand these things? But I've got a great description. Or if you're really interested in a fundamentalist right-wing cults, also a chapter.
That's my favorite.
Yes. Or how do you get into medical school? Or what's medical school like?
Mhm.
Oh, gross.
Oh, you talked-
anatomy.
you
It's
talked
in
about that.
there. It's in there, man.
All right, everybody, I'm reading a lot of books right now.
Yes, but he's
So,
about to get to this one.
This,
Yes, yes.
this is mine.
Yes.
Mine.
At Duke, we had our heights of our gross anatomy tables were fixed and they were by height. So you were at a group
Mhm.
of all people your height. Interesting, isn't it? Yes.
That's awesome.
Crazy, crazy. Yeah.
Alrighty. Well, till next time.
Thanks so much.
Talk soon.
Yeah, this was great.
Have a good
Thank you. Thank you. Thank you.
Ah.
That was fun.